So I think I'm starting 11th year as Executive Director of IRHA, and we've been blessed to have a group of people to be our State Health Commissioner, and that has certainly continued, because every time they change, you always, at least I do, get a little nervous, what they're going to be like and what's going to be their focus. But Governor Holcomb sure picked a winner, and Dr. Kristina Box. Like I say, I'm not going to spend a long time talking about her, but I could, but she just hit the ground running. She's very focused, she's very collaborative, hardworking, easy to work with, and as you'll hear, she's still got a lot of work to do, but she's starting to make a difference, and we really appreciate her. So please welcome Dr. Kristina Box.
Thank you, Don, so much. I appreciate that introduction, and I want to say that this is one of my favorite groups to speak with and to take time to meet with, and the collaboration goes both ways. I've always appreciated the relationship that I've had from IRHA, and you guys, Tina and Don, welcomed me from the very beginning when I started. I am Dr. Kristina Box, and I'm the Indiana State Department of Health Commissioner since October of 2017. So a little bit over a year now, so I should have some experience under my belt. I was joking about the politics of it all, and Tina said, "Oh, you should have that down by Pat by now." And I'm like, "Yeah, still learning on that one, Tina, to be honest." But it's truly a pleasure to be here today to take a moment to kind of update you on where we are on those 2019 health priorities or agenda items that you have heard before, that we have talked about before, but kind of where we are on all of those. It's also going to give me an opportunity to expand on Governor Holcomb's agenda items as we go forward. I'm trying to leave a good 10 to 15 minutes at the end for questions, so I will try to move along, but if you have questions throughout that are just burning and you can't wait to the end, feel free to interrupt me. Most importantly, I want to figure out with you, when it comes to the health of Hoosiers, how we can better collaborate together and how we can work to make us in Indiana in health the best at getting better. So those pressing health issues, as I'm sure you're aware, haven't really changed over the last several years. I know my predecessor, Dr. Adams, was talking about these same things. Those are the opioid epidemic, infant mortality, obesity-related health issues, and also adult smoking. We know that many Hoosiers in our rural areas have significantly higher issues with getting access to health care and other things that make addressing these problems much more significant. Governor Holcomb, for the first time, actually put public health on one of his pillars in addition to the opioid epidemic. So my team was really excited to see that this year and celebrating that. And he genuinely means that too. It's something that he's very concerned about. As part of his agenda, he wants to continue to address the opioid epidemic by expanding recovery housing, and they will be expanding level 1 recovery housing across the state. And have hired a company to come in and put a lot of that in. We also know that we need higher level recovery housing, and we will continue to pay for individuals to be in that recovery housing. We're establishing access to quality treatment by making sure that there are a set level of evidence-based requirements to be an office-based opioid provider across our state. And you'll see that legislation out there now. I can tell you that myself, the Department of Mental Health and Addiction, SAMHSA, and multiple other partners were involved, including ISMA, in making that. And it is not meant to be restrictive at all, or to tell people that are already doing addiction and mental health medicine extremely well what they need to be doing, but it is to set some parameters so that we know that every new clinic that opens up out there, a new treatment provider, has some baselines that they have or she have to meet. We also are going to be supporting the development of evidence-based family recovery courts across their state, and I'll talk a little bit more about the effort that's been made to work with our judicial system across the state on that. As we continue our pursuit of our quest to be the best in the Midwest by 2024 in infant mortality, Governor Holcomb is supporting a couple of really important agenda items. One of them is OB navigation, and of course, being an obstetrician, I will spend some time on that. And then the other is to make sure that a mandatory verbal screen is done of every pregnant patient to assess for substance use disorder and how that might be able to be used going forward. The governor is also supporting the adoption of the recommendations. I think there were 18 of them that came out in August of 18 with regards to school safety. One of those very important ones that Dr. Walpole and I had the opportunity to be involved with from the Department of Mental Health and Addiction was to address the mental health aspects that our schools need help with and the programming and the resources available for that. The second, of course, is physical safety enhancement of the schools themselves, and then policy changes that will go into effect around that. If you live in a rural area in Indiana, you know you're probably more likely to die of diabetes and cardiovascular disease than myself, who lives in an urban area. You may be more likely to smoke during pregnancy, and you definitely may have more difficulty accessing health care, or at least specifically specific kinds of health care, like mental health or addiction services. That's why events like this forum, I think, are so important, so that we can share ideas. I told someone once that my traveling to all 90, I guess there's 93 health departments, 91 counties, I really felt like a bee. I was just kind of pollinating one idea from one area to another and bringing those back to the State Department of Health so that I could use those and informing people across the state about what other great ideas are being used out there. We know that access to treatment for substance use disorder has been a major problem and a major barrier across our state. So the Indiana State Department of Health has actually partnered with HRSA in order to get a student loan repayment program for this. This is an attempt to attract more mental health professionals to our underserved areas across the state. The grants for the professional loan repayments for qualified providers will be first in mental health and addiction and the disciplines that are associated with those, but they'll be followed by primary care physicians, because we know that there's a shortage of primary care physicians around our state also. State Department of Health has committed $300,000 to this, and HRSA has committed to match that, so we'll have $600,000 to be used for that, and be giving 30 grants each year for the next 4 years across the state. We're actually in the process of developing an advisory committee through the Department of Mental Health and Addiction at FSSA and ISDH so that we can kind of set this program out. And we actually will be taking applications. You can actually get online now and apply for that. So I encourage all of you to look into that, and hopefully we can improve mental health services across our state. To illustrate the differences in health outcomes across the state, I wanted to use this one slide because it really strikes me as being a significant difference. If you look to the far right-hand side, you'll see the number of individuals in the rural health area that die of heart disease in Indiana is significantly higher than those in the urban area, which is the middle bar, or the state of Indiana overall, which is the far left bar. As you know, sometimes we have to get creative about delivering our health care across the state, and we know that there's a shortage of providers in a lot of our rural areas. So paramedicine programs, like the program that I got to visit several times in Montgomery County, where they actually go into the home and do follow-up services, a lot of times for individuals who have been released from the hospital, to check that weight, check that blood pressure, to make sure the medication changes got done appropriately, have been significant help in communities where we either don't have hospitals or we don't have that follow-up service readily available for individuals that have transportation problems. I'm sorry, I've had a little tickle. Also, telemedicine, as you know, improves access to care across the state and cost efficiencies. And I think rural health has kind of been the leader in this from what I've seen. And anytime I talk, when I had questions about it, I went to Don and Tina immediately, and they got me all the answers I needed as far as cost and other things that we were trying to work out for some other budget items we were doing. And I wanted to mention a little bit about Project ECHO, because this is an incredibly good program. When people ask me about the best programs that are out there and the ones that I have concerns about that aren't as good as what I want them to be, ECHO falls in both of those, only because we haven't had enough uptake of ECHO as far as I'm concerned. So ECHO really allows us to leverage experts in certain areas of medicine or certain disease processes to actually, through a computer screen, train providers across the state. So family doctors, advanced practice nurses, PAs that want to deal with a particular disease process. And then that expert also is backup kind of consultation for any type of management or care for that patient going forward. So you can actually call that individual, you can get online with them, you can discuss that patient care and get direction. This has been amazing. It's already in 30 of our states across the United States, and it's in 23 different countries, and it really has expanded healthcare and specialty services across our state. The initial ECHO that we did in the state of Indiana was a hepatitis C ECHO. Fairbanks School of Public Health put this into effect last January. I'll talk a little bit more about hepatitis C, but any of you who have been involved in the opioid epidemic know what a tremendous issue we're having with hepatitis C across our state. So by having this ECHO in place and training professionals in the communities, we can address these issues, and we can not only get a cure for this viral infection, because there's medication out there for this, but we can decrease those downstream effects that we see when hepatitis C goes untreated. For instance, liver failure. So the difference is between $25,000 or $35,000 to treat a patient versus maybe $500,000 to do a liver transplant on that individual, and all the complications that come with that. If you look at the success of this program and you talk to patients about it, this increases provider satisfaction, this increases patient satisfaction. When we look at outcomes based on this, the outcomes are the same or actually better in a lot of cases, because you're really getting to talk to an expert anytime you have a question or a concern about managing that patient. It has been significant in provider retention across states. And I think that's really important, because I know family doctors get overwhelmed in the rural areas having to be an expert in basically everything that they do. So my encouragement would be to find individuals in your community that are interested in doing this ECHO program and to sign them up. It is for free. I think it's an hour session for 12 weeks, but I'm not 100% sure on that. Someone here who did the ECHO may know that better than I. This really shows you, in addition to our hepatitis C ECHO in Indiana, we also have an opioid use disorder ECHO. And it has 3 different paths. It has a path for providers, a path for behavioral health specialists, and a path for community health workers. And I can tell you as an obstetrician, I need more MAT providers out there for pregnancy. So I'm really encouraging through the American College of OBGYN and the American Academy of Family Doctors, anybody who's providing obstetric services, please consider taking this program. You would have backup and support through specialists at IU Health and Community Hospital and other hospitals that have specialists in this area. There also is an ECHO out there for LGBTQ. This slide shows you a breakdown of some of those specialists that have been involved in this. We've had MDs and DOs and advanced practice nurses and PAs. We've had community health workers, licensed mental health professionals, recovery coaches, RNs. So a large group of individuals have been using these programs. Focusing just a little bit on the overdose epidemic. I know you've seen this slide before, but really that time in 2008 when the number of deaths that we had from opioid overdoses or drug overdoses overtook the number of deaths from motor vehicle accidents is amazing to me to see the climb since that point in time. And I show you this because the death rate for 2017, which is the most recent statistics we have for Indiana, is 27.1 per 100,000. As you can see, our non-fatal opioid overdoses also are increasing in treatment in the emergency room. I think that might be my phone going off. I'm really sorry if it is. I think it's a first for the year and a half that I've been here to have that happen. They've increased from 2016 to 2017. We actually went from 104 overdoses in the emergency room to 122, which was a 17% increase. The darker blue here represents the higher rates, and you can see the change. Believe it or not, we kind of consider this to be good news. And the reason that is because what it means to us is that we have more naloxone out in the field. We have more first responders are saving those individuals in the field so that they actually make it to the emergency room and to that hope of recovery and that hope of getting into treatment program. And this is a 5-year look back across the state of our drug overdose deaths. And as you can see again, the darker blue represents the higher rates. We have had ranges anywhere from 3.9 deaths in some of our counties across the state per 100,000 population to 58 deaths per 100,000. That's the dramatic changes that we see across the state. In 2017, as you would expect, we have seen an increase in fentanyl overdose deaths and other synthetic opioids. And we think that has really contributed as to why our numbers for overdose deaths did not go down in 2017. We did see a leveling off of heroin overdose deaths in our state, which is good news. And we have seen a decrease in our prescriber rate of opioids for the state of Indiana. We started out at about 106 opioid prescriptions per 100 individuals. We are down now. Last year, in 2016, it was 84 per 100, and now we're at 74. Just to give you a little context, though, the United States itself is at 59, so we still have a long way to go. We started very high, we are coming down, but we need to continue to address that on a regular basis. And I would say also improvement we have seen significantly in the toxicology panels that people are actually doing on our overdose victims, so we know more what our individuals are dying from across the state, and I'll share some more information on that later so that we can better address that. We won't have our finalized numbers for 2018 for 2 or 3 months yet, but I will say that the National Center for Health Statistics has shown a slight decline in Indiana for the last couple of months, like May and June of 18. So we're praying that that trend is going to continue. Although most of the focus, as you know, has been around opioids and those synthetic opioids that have come onto the scene, we are still seeing a lot of other illicit substances make their way into these tox panels as we look at overdose victims. We have seen, as you can see, 42% of cocaine mixed with the synthetic opioid and 44% of amphetamine mixed with synthetic opioids and 38% of the benzodiazepines mixed with synthetic opioids. So anything that we produce now, we need to make sure it is going to really be up and running to address addiction, right? Because right now it may be opioids, but it may be cocaine, it may be crystal meth in other parts of the state or in different years. We know that people who inject drugs are at risk for diseases like hepatitis C and HIV, and even in our Scott County HIV outbreak in 2015, we found that a majority of those individuals were actually co-infected with hepatitis C, well over 95% of those individuals. So the opioid epidemic is really creating a huge challenge for the state of Indiana when it comes to hepatitis C. And I feel like that this is one thing federally that we've really not addressed with regards to funding and support for this. So I'm hoping that the federal government and the CDC is going to catch up on that. Indiana has a confirmed hepatitis C case rate, acute rate, in 2016 of 2.2 per 100,000 population. Now that's just acute hepatitis C. That's not people that we've known have had that, compared to a U.S. rate of 1 case per 100,000. So Indiana's acute hepatitis C rate is well over 2 times the national average, which really is going to mean that in the long run, we're going to have some significant issues to deal with. All the more reason to get that hepatitis echo up and running in your community. We also look at the rates of hepatitis C in our rural population, and we find that in our rural population overall, 23% increase in hepatitis C in the rural population. And if you look specifically at the age groups of 18 to 39, that's 65% increase in the rural areas as opposed to our urban areas. So once again, something that I think that we're going to need to work hand in hand with the World Health Association to make sure that we're addressing. The opioid or drug epidemic remains to be a top priority for Governor Holcomb going forward. You can see here just a few of the efforts that have been just through the Indiana State Department of Health, and we can continue to collaborate and working on the local, state, and federal level, but also working between our sister agencies and with our drug czar, Dr. Jim McClellan, who basically runs this program for the state. All of us are working to increase access to services for those who are battling substance use disorder across the state, and I'll go into that a little more deeply. We're also educating our communities with the Know the O facts with regards to the stigma associated with this, and basically explaining the chronicity of this disease and the physiology and the biology behind addiction. We're also working to collect better data, which I'll talk a little bit more about, and enhance prevention efforts across our state, especially through our schools. State Department of Health continues to distribute naloxone across the state to local health departments and to our first responders, and to educate individuals about this disease process. We have actually been meeting at their request with faith-based organizations across the state, because their request has been, talk to us about this disease, explain it to us, give us the information about it, help us to understand the stigma associated with it and how we contribute to that. Help to give us resources so that we can educate our community here in our religious-based area, and also give us the opportunity to have naloxone, explain that to us, and how we might be able to save an individual's life. I always tell people when I first started, I carried the mask around with me for that individual that went down and needed CPR. That's no longer a part of CPR, and I have naloxone in my bag, in my purse, in my coat pocket, wherever I am, I always have it with me. And I think a lot of physicians do that. We are also working with our coroner toxicology program, which, as you know, was voted through legislation last year, and it requires every coroner in a suspected drug overdose case to do a standard toxicology panel. they can send that to one of 2 different labs, and they are across the state, and then that report gets directly sent to ISDH and back to the coroner. So we have immediate information for Jim McClellan and his team now with regards to that. And as of January 1st, we have every coroner signed up and doing this, and that has been a little bit of a challenge. We have enjoyed working with the coroners, though, in educating further about how to fill out that death certificate to make sure we have more accurate data. Because when we first got our death certificates, about 36% of them, well over a third of them, said an unknown quantity with a suspected overdose. And we're now down to about 20% of those. I expect that to continue to go down because we're becoming much more specific with regards to that overdose. We also saw the need for overdose fatality review in our state. Anytime you do infant fatality review, you do child fatality review, the purpose behind that is to identify those factors that you might be able to change and impact so that you decrease the chance of that event happening again. So the same thing with our overdose fatality review. Our child fatality review committee has stepped up to do that, and I've been very appreciative of that. We have worked with Volunteers of America to fund a program called Fresh Start, which is a very unique program that allows a woman to bring up to 2 of her children under the age of 5 and to get inpatient treatment and recovery for addiction. This is very helpful because a lot of women, the big barrier to them getting into treatment is the fact that they have children at home and no one else that they can trust to take care of them. And they don't want to be separated. But women are very motivated when they have small children or they're pregnant to get into treatment and recovery at that time. So this program has been very successful, and I've been very excited to see what Dove Health has done along these lines also. We already have a program here in Indianapolis and one in Winchester, which I believe is in Randolph County. I've been up there. And we'll have 2 more programs opening here in 2019 for that. At ISDH, we continue to work on timely data information, so our syndromic surveillance allows us to take information from our EMS and from our emergency rooms on an every 4-hour basis and to look at that and to determine where we see pockets of overdoses in our state. The importance of that is that as we identify those pockets, that probably means that there's a higher amount of fentanyl or other synthetic opioids that would be a risk for our first responders, for the nurses in the emergency room, for physicians, for the fire department, whoever's responding to that. So actually sending those alerts out through our local health department and working on a process now to make sure that that information gets from the local health department out to the local EMS, out to the local fire department, out to the local emergency rooms. We've also been very excited to see the workforce training programs that have been put in place in jails for prisoners that are there for substance use disorder, to train them so that when they get out, they have a job that's good paying, and that will be one less hurdle for them as they get out and start their new life, hopefully in recovery to remain there. And businesses are starting to hire individuals with substance use disorder around the state. I know there's a program in Richmond that does this, and as long as that individual is continuing to work that recovery program, it's all right if they test positive for their medication-assisted therapy, as long as they continue to be supported in that. Of course, we have the optin.in.gov to get naloxone, which any of you as a local citizen could go to any pharmacy and fill a naloxone script if you wanted to do that based on my order. Let's see here. Okay, so my next slide here, I'm going to go back one in a minute. ISDH continues to support communities that have syringe service programs, and the idea behind this is to decrease that spread of hepatitis, and we've seen hepatitis A, hepatitis B and C spread, and also HIV by operating a syringe service program. In the red here, you can see those 9 syringe service programs across our state. And if you look at statistics, individuals who attend a syringe service program are 5 times more likely to get into a treatment program. So we think that's another really important aspect. We also, in areas or communities where they're not ready to support a syringe service program, support what we call a harm reduction site, where the individual can come, maybe get a meal, get counseling, get tested for HIV, hepatitis C, and other things, get treatment, but they basically don't get the needles there. So if any of you are interested in that, we'd be happy to talk with you and to work with your community with regards to that. Moving back one slide, Jim McClellan, who is the director of our Drug and Prevention Treatment and Enforcement, continues to orchestrate this important work across our entire state and works with the federal government on this also. He continues to emphasize to all of us that the right programs and policies are being implemented and that we just need to make sure we continue down this path to work hard and not take our foot off the gas. So when people ask me, what do we need to do new? I'm like, we need to get this out across the entire state is what we need to do. Also, FSSA has worked to get more information out about Know the OFACs, which is basically the program that was developed to decrease stigma surrounding addiction in our state, to educate more people. So getting that out, and we can educate more people through the schools, through YMCAs, through religious-based organizations, I think is very, very important, so we have a better understanding of this disease. We're also working to expand treatment across the state, and I'll have a couple of slides on that, and to address substance use disorder wherever we meet that individual. So for instance, we commonly meet them in the emergency room. We've just given them naloxone a lot of times and they're going through a whole withdrawal. So the last thing that they want to do is actually talk to that peer recovery coach. They want to get the heck out of Dodge, right? Because they feel bad and they want to get another fix, basically. So bottom line is what we're trying to do is start medication-assisted therapy in some of these emergency rooms across the state, give them enough to last for 48 to 72 hours so that we can then transition them into an outpatient program. And that's being piloted now around the state with the Department of Mental Health and Addiction. We're also working to make sure that we meet them in jail, give them further counseling, treatment if appropriate, job training, so that they're better prepared, because we know that that individual that comes out of jail that has not had this addressed is very, very likely that they may have an overdose and die from it because their tolerance has gone down so much at that point in time. And then I wanted to mention the work that the FSSA, Department of Mental Health and Addiction, and Jen Walthall did with the judicial system this past summer. We partnered with Chief Justice Rush, who is the head of the judicial system for the state, and she basically worked to get over 1,000 participants in Indianapolis this summer. And the training was basically around what can the court systems do differently, what good evidence-based programming is already in the court systems that maybe we could roll into other courts across our state. So there was training in pre-arrest diversion, there was training in the science behind addiction so that we could help people to understand addiction and help people to understand the stigma associated with that. There was training about connecting people to care and what resources are available for that, and then workforce development, whether in jail or out of jail, and supporting those individuals, and data sharing was a big part of that. And that was a very successful thing, so I think that's part of why the governor really wants to support these family courts across the state. As you can see, based on this next slide, the Department of Mental Health and Addiction at FSSA is continuing to expand opioid treatment programs across the state. We actually have 25 new addiction treatment providers. I know that doesn't sound like much, but that's been a stretch to even get that. So we have a total of certified addiction treatment providers of 253 that are providing services in 448 locations across our state. We also have 5 new opioid treatment programs for a total of 18 across our state, and you can see that here on our map. The green are the existing opioid treatment programs, and the blue are the ones that should be added here in 2019. And we have 30 new SAMHSA designated addiction residential treatment facilities and units that opened in 2018 for a total of 659 beds. This slide shows the existing treatment centers in Indiana in the darker blue, and then the 5 new locations that opened in 2018. So, moving on to infant mortality, as an obstetrician, I feel very blessed to be working with a governor who is addressing infant mortality in our state. As you know, he's challenged us to be the best in the Midwest by 2024. And that's a tall order, as my grandfather would say. We're looking to go from being the worst in the Midwest to the best in the Midwest. But I have every faith with the programming that we're developing and the partnerships that we're developing across the state with rural health and with our hospital association, we're going to be able to accomplish this. I'm happy to report that Indiana's infant mortality rate from 2016 to 2017 did go down. We went from 7.5 infant deaths to 7.3 infant deaths per 1,000 live births. I'd like to take credit for that, but there's a lag time larger than that, so I believe this is totally related to what the Indiana Perinatal Quality Improvement Committee and IHA and Rural Health Association has been doing in these last 2 to 3 years. Although this is something to celebrate, we still had 602 babies that lost their lives before their first birthday in Indiana. And that's, as an obstetrician, just not acceptable. Losing one is beyond heartbreaking. So I celebrate it, but I also look forward to that number going down even further. Unfortunately, as we break this down further, what we saw is that decrease in infant mortality was amongst the white population, which is great. And when we look at it ethnically, amongst the Hispanic population, we saw a decrease from 9 to 7.6 in the Hispanic population. But unfortunately, if you look at our black population, which is the green line here, you see that our black infant mortality from 2016 to 17 actually went up from 14.4 to 15.3, which underscores what we've been saying, and that is that our programming and our resources really need to be directed toward these high-risk, disparate populations. I wanted to give you an idea of where rurally we stand with infant mortality as opposed to urban. When you look at this in the past 5 years, from 2012 to 2017, it's hard to see the difference between Indiana as a whole and the urban population, which is the dark blue and then the lighter blue. But as you can see, the rural health has actually fallen from 7.4 to 6.5 when it comes to mortality rates. So congratulations on what you're doing and keep up the good work. Let's figure out how we can make sure that gets out to all of our rural populations across the state. We continue to track what our babies die from at the Indiana State Department of Health. We actually know this very clearly. About 46% of our babies die from what we call perinatal risks. The most common risk there is that a mom goes into labor early and has a preterm delivery of her baby, or she ruptures her membranes early, and that leads to preterm delivery. And babies that just aren't strong enough to live out in the world and breathe the oxygen on their own and function. Unfortunately, babies that do live sometimes end up with significant morbidity or die later in their care. We also have seen about 14% of our babies, and unfortunately, as we reveal the data for 2017, I think that goes up to 16% of our babies dying of sudden unexpected infant death syndrome. When the State Department of Health looked at this, we found that a very large percentage of those are from unsafe sleep, like 96 out of 101 or so. It's amazing. And to me, that seems like a simple thing, right? The message is the ABCs alone on their back in a crib. It is no bumper pads, it's no blankets, it's no stuffed animals. It's a baby on its back in a sleep sack in its crib. Not with a parent, not with another child, not sleeping on your chest, a baby alone on its back in a crib. And we've been giving out cribs all over the state, and that's important. What's more important is the education that comes with it. We're educating in all of our hospitals, all of our parents of the babies. I think it's more important to get to grandma and grandpa and aunts and uncles and cousins, because I really think that's where the pushback comes a lot, because my mom put me to sleep on my stomach and I just did just fine, right? And that's going to be the case most of the time, but we know that statistically babies are more likely to die on their stomach than they are on their back. We also know that about 22% of our babies die of congenital birth defects. And when you look at that, people would say, well, it's genetics, Dr. Box, you really can't do much. But in reality, you can. If we get to that childbearing age group of women and get them on prenatal vitamins with that extra folate, beef up that folate in their diet, we know we decrease a significant category of birth defects called neural tube defects, spina bifida, those types of defects. We also know that women take certain medications. Some of them we prescribe legally for them during their pregnancy or during their pre-pregnancy time that we just can't use in pregnancy. So it's really about seeing that woman. Somebody asked me once, Dr. Box, do you really want to see them in the first trimester? Don't you want to see them after 12 weeks? But the reality is no. I would prefer to see them preconceptually, right? But if I don't get that opportunity, as early in that first trimester as I can, so that I can address things like smoking and substance use disorder and medications that they're taking and other habits that they may have. When we look at maternal risk factors, Indiana has a high infant mortality rate because we have high rates of obesity, which lead to high rates of high blood pressure and diabetes. It leads to high rates of our maternal mortality because of cardiovascular disease. We also know that Indiana has a high rate of maternal smoking. 13.5% of our pregnant moms across the state smoke, and that's well over 2 times the national average. And I will show you some statistics that are a lot higher, unfortunately, in our rural areas. We know that Indiana doesn't do a very good job of getting women into prenatal care in the first trimester. In fact, in our black population, we see about 55% of women being seen in their first trimester, and that's actually gone down. Overall, Indiana's at about 69%. We'd like to be close to almost 80% by the Healthy People goals. And I've mentioned the unsafe sleep. We truly believe that our levels of care that is going to go into effect, it was voted through legislation, the governor signed it last summer, and now we basically are in the process of getting those rules through, which I never imagined it could take so long to get a set of rules through, but I'm learning. And those rules are now out for public comment. There'll be a public comment or hearing here coming up. Once those rules are completed, hopefully by late first quarter, early second quarter, we'll be able to start surveying all of our hospitals across the state for levels of care, not only for mom's care, but for baby's care. We know that other states that have done this have shown decreases in infant and maternal mortality, and in case I didn't mention, we have the 7th highest infant mortality rate, but also the 3rd highest maternal mortality rate in the state. So everything we do is to direct to the mom and the baby's health. Moving on. Let's look at low birth weight babies, because this is oftentimes a cause associated with having diabetes, severe diabetes, or high blood pressure in pregnancy. It could be just that preterm baby. It's not the very low birth weight baby, but it's the baby under 2,500 grams, which could include that. As you can see, again, the low birth weight babies in our urban area has gone up, but the low birth weight babies in our rural areas have actually gone down. So again, whatever you're doing to address this, we need to continue to just expand that and grow those programs. And we look at the percentage of preterm birth, those babies under 37 weeks. We can see that preterm births have actually gone down across the state of Indiana and in our urban areas and in our rural areas, just slightly, but they have gone down. And rather than going up, that's a good thing. When we look at percentage of breastfeeding at the time of discharge, overall, all areas, Indiana as a whole, urban and rural, are doing a very good job with this. It's continuing to improve. But as you can see in our rural areas, which is the lighter green line there, we still lag significantly behind. So we still have areas of improvement to continue to educate moms about the importance of breastfeeding. And I'll reiterate this later, but breastfeeding not only decreases infant mortality, but it decreases childhood obesity. 2 very, very important things for the state of Indiana. So addressing the smoking rate amongst our pregnant women is critical if we want to reduce infant mortality. Smoking is really one of the most important modifiable factors that causes poor pregnancy outcomes in the U.S. and in the state of Indiana, and it's associated with maternal, fetal, and infant mortality. We know that of our childbearing women ages 18 to 44, 23.2%, so almost 1 in 4 women in this age group smoke. 13.5% of pregnant women, as I've mentioned, across the state of Indiana smoke. That's over 2 times the national average. And we have 11,100 births per year that are affected by smoking, to the tune of about $15 million of additional health care costs because of the preterm babies, usually that are born secondary to this. And on average, 24% of mothers who are covered by Medicaid smoke. Unfortunately, some of our counties have even higher rates of smoking during pregnancy. You can see here again the darker blue represent the higher rates of smoking, and some of our counties have rates up to 40% of moms, almost 50% of moms smoking. Although the rates of smoking in pregnancy have been decreasing in Indiana as a whole and in our rural and our urban areas, as you can see, once again, the rural area lags significantly behind our urban area and the state of Indiana. Rurally, we have about 19.1% of our moms that are smoking during pregnancy, whereas Indiana is 13.5 again, and in our urban areas it's 11.9. So if there was one area that I would say that we really need to partner together and we need to work together to address, I would say it's smoking during pregnancy. We have baby and me tobacco-free programs in 28 of our areas across our state, serving 60 different counties, but I'm convinced that just traveling to that other county to do the Baby and Me Smoking Tobacco-Free program is part of the barrier to why women do not do a better uptake of this. What we have seen, one program through safety pin dollars actually embedded this in their clinic in Anderson, Indiana. They are now serving over 200 patients at a time. And this is because they're embedded in the clinic where women are already coming to get their labs done, to see their provider, and to get their testing done. So I'm convinced that I need to work more with FQHCs, community health clinics, with hospitals where they're seeing patients, to embed these programs there so the ease of access is very easy for patients going forward. Another challenge that we face in rural areas is access to care, and you know that 33 counties either have no hospital or the hospital has no obstetrical services. I think this was probably one of the biggest eye-opening things to me when I took this position. This really is an issue of getting obstetrical care closer to home. When I went to make a map of obstetrical providers across our state, no one could tell me where we had family doctors that were doing obstetrics. That information was nowhere to be found. So I finally, through Hannah Bowen or Hannah Maxey at the Bowen Center, got some information, and we were able to put that together on a map. But that was like the first step, right? To know where we have providers. I think going forward, we might be able to help those providers even, or to help those areas that just don't even have any providers, or family doctors in areas where they're just too busy. You know, when I was in Fountain Warren and met the local health officer there, he's up at 6:30 or 6 in the morning making rounds at the hospital, in the office by 8, leaves the office by 5:30 or 6, and back to the hospital. That's the kind of obstetrics and programming and medicine that I did when I first started my residency, that you only see out there, I think, in the rural areas anymore. That is not the way it works in the hospitals in our urban areas anymore. So what we really need to do is to be able to get obstetrical providers, whether that's an advanced practice nurse with a specialty in obstetrics and that first year of the baby's life, or whether that's a nurse midwife, to partner with clinics that do have obstetrical care, to go into these areas where we really don't have obstetrical care. See those patients in a family doctor's office that's too busy to do obstetrics, in an FQHC or community health clinic that may not have obstetrical services there, or actually in that individual's home. Whatever works best in the community. I'm not the person to say that, but I want to make that offer, and part of the money that I've asked from the legislature this year is to see if I can have seed money to help start that around the state. So if you have an interest and you're a county that wants to get out there and get on board, please contact me about that. I've also been working with partners such as the Rural Maternity Medical Home Collaborative that's helping to serve the maternal and child health needs of southwestern Indiana. I've been really excited about that because it's a lot of people from my area, or my neck of the woods, as I would say, having grown up in Terre Haute, Indiana. They are working to make sure that they have a form of perinatal navigation throughout pregnancy to support and educate at-risk moms. And so I'm excited to be working with them on that. This is kind of a roadmap for 2024. Many of the things we've already talked about here, the perinatal levels of care. I'll talk a little bit more about the OB Navigator and the perinatal substance use disorder, and then talk a little bit more about this preterm birth and IM progesterone in just a minute. Also, we know that women that have severe hypertension are at risk or have had a prior baby with preeclampsia to get severe preeclampsia again. A simple baby aspirin that is started early in pregnancy at say 16 to 20 weeks and then continued through about 37 weeks can dramatically decrease that. So I would continue to educate and work with your partners in your areas to talk about things like this. We talked about smoking and safe sleep. The Live app is actually a great resource, and so I'm working with IU hospitals, and I want to go from one hospital system to another to see if we can't get that Live app kind of downloaded on every woman's phone, because there's all kinds of information about what you can eat, what you can and can't do, you know, can you sit in a hot tub, all of those questions that our offices get asked on a regular basis, and connection to resources for whatever area they're in. We're in the process of trying to put geofencing into that, so the map will actually be able to know where the individual who's accessing this information is and push out resources that are local to them there. Got my maps mixed up. So this is the map with regards to the progesterone pilot. And I wanted to show you this because some of the counties here are very definitely rural counties. As I mentioned, a significant proportion of babies die because they're born very preterm. And the number one risk of having a preterm baby is that you've had a prior preterm baby. So it's really important to identify that woman who's had a prior preterm birth and to counsel her about the option of taking a medication called progesterone from about 16 weeks of pregnancy through 37 weeks of pregnancy. And we know that that statistically, evidence-based, decreases the risk for that woman having another preterm birth, and therefore, hopefully, our infant mortality and morbidity associated with that. We have an Indiana Perinatal Quality Improvement Committee working on this. One of our maternal fetal medicine specialists from the Muncie area is really leading this charge. Let's see. And this one I really wanted to show you because the IRHA grant that is being used to address the central southwestern area and the infant mortality rate there basically will cover these counties here. I've been talking a lot with Cindy Large and Heather Grable, and I've mentioned the partnership that we're trying to develop here. And so I'm hoping that the state is going to be able to support by giving information and contact information for women who are pregnant in these areas so that we can reach out to them and get them into prenatal care and get them into connected with resources and services. And then, as I mentioned, Governor Holcomb supports establishing an OB Navigator pilot program in our highest risk counties that also incorporate our highest risk zip codes. Here in the darker blue, you can see the highest risk zip codes, which I know we're going to cover 100% those zip codes. This map is pretty preliminary right now because this all depends on legislators and what they do with this bill and whether they give us the money to do this. So whether I will have the workforce, because I have to develop a lot of workforce in the form of nurse-family partnerships and community health workers and paramedicine in these areas, and whether we'll have the money to do it will depend on the next several months, but we're working hard at that, and I believe that we'll get support for this. But the important thing here is that what we can do is attach women in these high-risk areas that are covered by Medicaid to an OB Navigator. You might say, what is an OB Navigator? Well, an OB Navigator is just a community-based healthcare professional. It could be a nurse from Nurse Family Partnership. It may be a community health worker that has extra training in pregnancy and that first year of the baby's life. It may be paramedicine, like in Crawfordsville, which is what they have, and they're very excited on getting on board about perinatal care. It may be Healthy Families, which is currently used mostly by DCS, and we have in all 92 counties. We're actually working with Terry Stington, the director of DCS, to kind of repurpose that program to see if we can't get that program involved earlier with families so that there's less of that need to remove the child from home and more of that support through this entire process. We'll then pair that OB patient with one of these navigators and base that on visiting the patients in their home, and who they get attached to will be based on their geography, what programs are available in their areas, what hospital they deliver with. So what does your hospital usually use for our community health worker group or nurse family partnership group? And then also their risk factors, which will be assessed through ISDH. The goal here with the Navigator program is to identify women as early as possible in pregnancy, and we'll use Medicaid data to do that. And then as part of their Medicaid services, offer this wraparound service with a navigator. And then that navigator can help us to address getting that woman into prenatal care early and helping her to sustain that care through her entire pregnancy. We'll also be able to address those medical problems that a mom has, like high blood pressure, obesity, and diabetes that contribute to maternal and infant mortality. We'll be able to address those habits like smoking and substance use disorder that contribute to maternal and infant mortality. And we'll be able to address, most importantly, those socioeconomic factors that we know become a major barrier, especially in some of our rural and urban areas, to a woman getting into care and remaining in that care. We have a couple of really good examples of this through our safety pin grants. One of them is down in Vanderburgh County, which is called Pre to 3, and the local health officer is over there. They've hired a nurse in the local health department to oversee community health workers that then partner with pregnant patients, follow them through pregnancy and for the first 3 years of a baby's life. St. Joseph County in northern Indiana was having a particular issue with high Black infant mortality rates, so they went to the Black community and hired doulas from that community that have been very successful in getting women in care, keeping them in care to the point where most of their referrals now are coming from women who have been through the program, and many of the women who go through the program say, hey, how can I get trained as a doula? I would like to be a part of the same programming. So again, using doulas as part of our navigation. This diagram is just kind of a cute way that Dr. Walthall and her FSSA team developed to depict kind of a woman with Medicaid information who is covered by Medicaid, actually going through the risk assessment at Indiana State Department of Health within like a questionnaire and kind of a call on the phone, and then being assigned to NFP, community health workers, paramedicine, or healthy families based on her risk factors and geography and where she plans to deliver. We know that the drug epidemic is contributing to our maternal and our infant mortality across the state. 44% of Indiana's female overdose deaths were in women ages 20 to 40. The pregnancy is an important opportunity to identify and treat these women, and that's why the governor has made this a part of his agenda. He wants every woman to be screened with some type of a qualified verbal screening tool so that we can identify these women and then get them into treatment. We know, I guess I've been talking a lot longer than I thought, sorry. We know actually, based on our pilot study across the state, that Indiana has higher rates in our high-risk babies of opioids in the cords. We have higher rates of barbiturates. We have 18% of our cords testing positive for cannabinoids. So we know that we basically need to address this. By doing that brief verbal screening with the patient, we can then do a brief intervention to talk to the patient about the risks that she experiences and the risks that the baby will experience, and ask her if she wants to be in treatment, give her the hope of recovery and of treatment. This really is to show you that smoking is the single most preventable cause of death and disease, that we do have 22% of Hoosiers now that smoke on a daily basis. So we went from being the 10th highest smoking to the 8th highest smoking state in the nation. We look at this and we know that certain groups, like those with lower socioeconomic, lower education, mental health issues and depression, and those who are uninsured or unemployed, have higher rates of smoking. We know that there's a significant personal cost, but also a significant individual cost and fiscal cost to the state of Indiana. As you can see, rural health rates of smoking exceed urban rates by about 25% to 22% across our state. We've worked and been able to bring our youth smoking rate down significantly. We've actually seen a drop in high schools of 74% since 2000 when we first started collecting data, and 82% since we started collecting the middle schools. Although I'd like to celebrate that, we still have 3,100 youth that become smokers on a yearly basis. And more importantly, what we're not talking about is e-cigarettes, which is now the #1 form of tobacco product used in our state and across our nation. The youth love it because basically it's easy to hide, it's like the size of a flash drive, it comes in flavors. And Jerome Adams, as I'm sure you guys all know, our Surgeon General, has declared this an epidemic across the United States because we've seen a 78% increase in high school students in 1 year and a 48% increase in middle school students. In Indiana alone, we have seen that 30% of our seniors are using e-cigarettes, and that was a 45% increase in just 1 year. So we have a significant problem. It's not just the rest of the world. We have actually sent out letters to schools alerting them to this and offering our resources across the state. We've also made sure that schools not only are a no smoking campus, but also a no e-cigarette campus. We have 75% of our campuses that are both. So if you have campuses in your community that are not both, would you please contact me? We need to work with them to make sure that policy is in place. When we look at e-cigarettes, we really don't see a difference between our urban and our rural areas. I'm not going to go over the tobacco quit line because I know you're all familiar with that. Just to say about obesity, we are the 10th most obese state in the nation. We went to the 12th most obese state. It's not because we lost weight, it's because we didn't gain weight as fast as some other states did. We still need to address this. I'd like to give you the facts the way they are. We know that obesity increases the risk for high blood pressure and diabetes. It increases the risk of heart disease and stroke. And heart disease is still the #1 killer for men and women across our state. 600,000 Hoosiers suffer from diabetes, and 1.8 million Hoosiers are at risk for prediabetes, and probably don't even know that just based on their weight and lack of activity. We know that obesity has costs to the state of Indiana in a fiscal form, just like it has individual costs, and a lot of those costs are picked up by Medicare and Medicaid. What we're doing, what I'd like to talk about most here that I want to make sure we partner with you on is that we're trying to increase our national diabetes prevention programs across the state. That's a CDC evidence-based program that really addresses increasing activity, eating healthier, and by nature, you lose weight that way, which decreases the risk for type 2 diabetes. We have 78 locations across the state right now, and you can see those here on the map, and I'd like to be able to increase those across the state. We also have WIC supporting breastfeeding across the state, which, as I mentioned, decreases infant mortality and childhood obesity. And Indiana WIC was one of 2 states to win a major award this year for their increased support. And lastly, just a quick update on hepatitis A. We have 915 cases thus far across the state, with usually about 20 per year. It has a 50% hospitalization rate. Again, hits most commonly in the homeless, the incarcerated, men who have sex with men, and those who use illicit drugs. And we've administered nearly 100,000 vaccines, with a third of those being in pharmacies across our state. ISDH continues to support our strike teams and are happy to come to any of your communities to help immunize these at-risk populations. And my recommendation is we all get immunized. We're immunizing all of our children. Why would all of our adults not get immunized? Fortunately, this year, influenza has had much slower and a much lighter start. We've had 4 deaths, which are very, very unfortunate, but as compared to 50 last year at this same time, it is much better. Mostly we're seeing H1N1, and fortunately our vaccine has covered that. So sorry, I timed this at home. It was like 46 minutes, and then I get up here and I'm more chatty. And so if there are questions, do you want me to take a couple questions or not? Any questions that I can answer for anybody? Yes, sir.
In the year 2040, what do you see the role of opioids being in a physician setting with prescriptions? What will we be able to use them for?
Well, I think there's always going to be a place for opioid prescriptions, right? We're going to have people who need narcotics unless somebody designs and develops a whole new drug that is totally non-addictive. And then opioids, as we know them today, will go away completely. But what we need to do is be smart about how we're doing that. I mean, the #1 surgical procedure in the state of Indiana is a cesarean section. We give on average 30 or 40 tablets, and studies show that patients use 12 to 15. So what happens to the rest of those tablets? They sit in your medicine cabinet so that they can be diverted or given to someone else. So we need to help make sure that we get physicians to prescribe less, more appropriate amounts for what they're doing, and also make sure that they help their patients get rid of those medications. Anything else? Thank you. Oh, yes, sir, I'm sorry.
Just real quick, you mentioned early on in your discussion, and I appreciate everything that you just elucidated us on, but with regard to the level 1 recovery housing, can you talk a little bit more about the specifics and the qualifications that are required? With our IOP and our addiction medicine program, recovery housing is going to be extremely important.
Absolutely. I think that's probably our #1 barrier right now, especially also for women to be able to bring children with them. I'm forgetting the name. It is a national based recovery housing, Oxford? Yes, thank you. That the state of Indiana is coming in, and they're going to increase recovery housing by, I think, 25 to 30 across the state. I know Jim McClellan has more information about the specifics of that, so if you give me your card, I can connect you to Jim's main guy who knows all of this, and I'll be glad to do that.
Thank you.
Anything else? Yes, sir.
With the increase in tobacco or vaping and your concerns about the impact of smoking on the health of several aspects of our communities, what are your concerns with regard to the pressures for policymakers to legalize, normalize, and medicalize marijuana?
So here's what I'm going to say. 18% of my babies at risk were already testing positive for marijuana, and it's supposedly an illegal system, an illegal substance here in our state. We know that marijuana increases the risk of ADHD issues and visual spatial problems in babies, that they don't do as well in school, and that they don't progress as well through school and achieve the same levels. And we know that it's kind of hard to sort it out with regards to the opioids, but with regards to marijuana, we have a lot of higher socioeconomic families that, do a really good job of taking care of their children, but they just think smoking marijuana or using marijuana in different forms is okay. So there are really good studies out there on that. So, I feel about marijuana that I do anything else is that people are saying about e-cigarettes right now, well, we don't have the evidence to show that they're dangerous. I'm like, that's what they said about cigarettes 40 years ago and 30 years ago. I'm not accepting of this, I feel the same way about marijuana. If we're going to use marijuana to treat certain medical conditions, I think it should go through the FDA. It should have double-blinded placebo studies that show that it's effective. And also, in addition to showing that it's effective, that it also has reduced side effects, right? Because there may be some very effective drugs out there that help with certain things, but there are better drugs because they have less side effects or less negative effects on an individual. So, as a healthcare provider, I'm not on the rah-rah bandwagon for that. Yes, sir.
Yeah, I think one of those components too is that the medical legal aspect of that, as well as what hasn't been fully evaluated, is the CBD oils that are out there. I'm currently doing a controlled ingestion study, and individuals are testing positive for THC in their urines and in blood when they're taking CBD oils. So I think in terms of the medical legal challenges they could be facing are pretty severe, and there should be a lot of caution and thought going into that process.
Very good point, sir. Yes, ma'am.
In the state of Indiana, vaccinations are required before school entry. Has the state of Indiana moved forward to lead-based testing prior to entering school?
So we haven't moved forward with regards to we're going to make it so you can't come to school if your lead tests high. But what I have said is that we're trying to do a lot of work with our providers and providing report cards, because we know by law, if you see a child at 12 months and at 24 months, you have to do lead testing for any individual that's covered by Medicaid. And we know that only about somewhere 15 to 30% of individuals are getting tested. So, you know, lead is one of those things that I think that if we could just do a hard push in the state of Indiana to get rid of these leads from home. Very few of it is actually environmental in the ground. Most of it is in the lead-based paint that is still in these old homes, and kids move in and out of those homes. So I'd like to partner with someone like Habitat for Humanity. Rather than building new things, could we go in and replace these windows and replace this lead paint in these homes and make this so this is not an issue anymore? Yes, ma'am.
Well, the reason why I'm asking the question is because Terre Haute has the oldest average housing. It is in our soil, even in the urban area. But we do not have 100% practitioners testing children before the age of 3 for lead.
Right. And by law, they're supposed to test. So I don't really know. I don't know how to force them. I'm not looking to arrest individuals across the state and put them in jail for it. But I do think that the awareness needs to grow. Actually, I would love to have money to develop a huge statewide program to do that. I think I better quit because I know I've gone over my time, and I'm sorry. Thank you, guys.